Hi, good afternoon, everyone. Thank you so much for joining us. My name is Rosamine Babbitt. We have quite a few people on already, so we should just get started. This is our fourth webinar on this topic, which is the telehealth guidelines during COVID-19 public health emergency. So, things are changing rapidly. Medicare is updating things rapidly, and changes are coming through, and it's really hard to keep up with everything, but we try and get you the most latest and updated information as we can. So let's get started. First of all, welcome everybody. If you have joined us for the very first time, welcome. And if you are joining us again from previous webinars, welcome back. I hope that you guys are getting some good knowledge and good updates from us. I would really appreciate it if you guys can also fill out the surveys that we send out after the webinar, so we can get some feedback on how we're doing, and we can continue to provide these updates to you on a regular basis. All right, so, okay, that's not what I wanted to do. Go ahead. Okay, so our agenda is very simple. We're going to actually talk about the CMS press release that came out on April 30th. That's the basis, that's the focus of our webinar today. We're also going to touch upon some commercial payers. I'm going to talk about some changes that some commercial payers made. But of course, you have to understand commercial payers do change things according to their whim and their policy. So we will talk about them briefly. Then we're going to also talk about some, oh wait, my thing is going on its own for some reason. Here we go. Okay, so then we're also going to talk about the COVID-19 testing. So there's a couple of CPT codes that were added by American Medical Association. So we will definitely be talking about that. And then the Q&A, okay? I do want to put a disclaimer out there for everybody that we try our best to provide you with the most updated resource, updated information with citing various resources such as CMS and other insurance payer sites, but we do encourage you to conduct your own research based on your specialty by regularly visiting the payer sites. And also wanted to give you another disclaimer here is that what we do at CodeRite is we work with physician offices, independent physician practices. Okay, my screens are going on for some reason. I'm not sure what's going on, but I'll revert back to this. So what I was saying is that we work with physician practices, independent physician practices that are built to Medicare for fee-for-service. So if you are coming on this webinar from a hospice or a home health or other inpatient coding and things like that, I will give you a lot of resources. I will give you links that you will be able to see and refer to, but mostly we will focus on physician fee-for-service for the purpose of this webinar. Okay, if it doesn't jump on its own, I will go further. Okay, that's me right there. My name is Rosamine Babbitt. I am the founder and CEO of CodeRite Healthcare Consulting. I am a certified coder and auditor from AAPC and AHIVA. And I've done everything from front desk to office management to coding to billing, everything. So kind of coming from the trenches here. CodeRite Healthcare Consulting was established in 2015. We are based in Allen, Texas. We work with multiple providers and multiple specialties. We bill for neurology, cardiology, pediatrics, internal medicine, psychiatry. We do all and we can do that for any specialty anywhere in the country. Okay, go back. Whoa, I'm sorry, I really do apologize about this. I should have checked this before the webinar. I'm not sure what's going on. We are #1 in client satisfaction. You can Google us and you can see all the wonderful reviews that our clients give us. We do focus on medical billing, and coding and compliance is a big part of what we do as well. So HIPAA compliance, policies and procedure manuals for medical practices, audits and reviews. We do specialize in all of those things. So do check out our website when you can. I will have the website information towards the end of the video, so do check out our website, do check out our reviews, and if you need our help with any of these services, do reach out for sure. Okay, so now let's get into what we are doing for today. It's April 30th. So CMS came out with an update to the COVID-19 emergency declaration page, declaration blanket waiver, which was the waiver 11835. Hold on just a second. Let me see. I don't know what's going on here. Why it's got a mind of its own. Okay. So this here is the update to the blanket waiver that came out on March 18th. This is the latest update. I do have the link right here for that document. So what they have said is that the retroactive effective payment date for all the COVID-19, all the codes is going to be March 1st. So if you have any claims that are sitting there that you haven't billed for telehealth, they will be retroactive for March 1st. I believe it was March 17th or 18th before, but they've put it all the way back to March 1st. And of course, there is no end date yet for this public health emergency. So we don't know what the end date is. Some of the payers, some insurance, private payers have put an end date on there, but Medicare and CMS has not put an end date on this public health emergency yet. There's another thing that was updated in this was eligible practitioners. Before, physical therapists, occupational therapists, speech language therapists were not allowed to perform certain services via telehealth, but now they are also included in this service to provide telehealth service to their patients. Okay, moving forward. So I have a lot of, you will find a lot of links within this document. I am going to upload the PDF file to this webinar after this webinar is over today. So you will be able to find all these links, and these links are very, very useful. Okay. Something's wrong here. I'm sorry, guys. Something is wrong here. Bear with me. All right, so next update is the removal of frequency. Oh, let me put my slideshow here. Removal of frequency limitations on Medicare telehealth. So there were some limitations that you could not provide a telehealth service in an inpatient setting for subsequent service to a patient. You could only do that once every 3 days. That restriction has been lifted. A patient who is in the hospital can be seen via telehealth every day. The codes that you will use are 99231 and 99233. If you remember, or if you go back to the first webinar that we did back on March 26th, there were G codes that Medicare had put out for providing telehealth services. That's no longer the case. What they're saying is that you would use the same CPT codes that you would use if you had seen the patient in person. So for a CPT, if you were seeing the patient in the hospital for a subsequent hospital care, it's 99231 to 99233, and you will use the place of service as if you would see the person face to face. And in this case, for inpatient, it would be place of service 21. Subsequent skilled nursing facility visit can be furnished via Medicare telehealth without the limitation that the telehealth visit is once every 30 days. So that also has changed. Critical care codes may be furnished to a Medicare beneficiary by telehealth beyond once per day limitation. So this is huge. So if you guys as coders know that, when you are seeing a patient in critical care, no matter how many times that you see the patient, you could only bill once for that critical care service. Of course, you had add-on codes and combined codes, but this can be done multiple days, multiple times in one day. So that's new as well on this. Workforce, Medicare physician supervision requirements. So I do get a lot of questions about the supervision requirements, because a lot of physicians have nurse practitioners and physician assistants, mid-levels, who do see who do see patients. So Medicare's incident to guideline is basically, you could see a patient, a nurse practitioner could see a patient, and it could be billed under the physician's NPI if the physician is in the same suite. The physician doesn't have to be in the room with the patient, but you could only do that for patients who are coming in for established services. You could not bill incident to for a new patient. That still stands. Okay, so but what they're saying is that for direct supervision, you don't have to be in the same place, you don't have to be in the same vicinity, but the physician can provide supervision using the audio video technology. So both the nurse practitioner and physician can be on the same call with the patient, and it can be billed under the physician's NPI. But please take note, this is not applicable to new patients. It's only applicable to established patients, because established patients qualify under incident to billing, not new patients. Medicare advanced practice non-physician practitioners, nurse practitioner, clinical nurse specialists, certified nurse midwives, and oh my God, this needs to stop, sorry. Practitioners will need to continue the required statutory relationships with supervising collaborating physicians. Okay, so even though CMS is saying that they're allowing all this under the blanket waiver, whatever the scope of service is for a nurse practitioner in their state is going to trump whatever CMS is saying. So if a nurse practitioner can't do surgery, it's not in their scope of work, then of course, you know, even if Medicare says, yeah, you can do it, but state of Texas doesn't allow a nurse practitioner to perform surgery, a nurse practitioner cannot perform surgery. So be very mindful of your state's requirements. Okay. I just wanted to let you guys know that please hold your questions till the end. We will address all the questions at the end. Okay, so what are the documentation guidelines? Okay, so documentation guidelines. Reporting and documentation for office visits performed via telehealth may be based on medical decision making or time on date of encounter utilizing 2020 definitions and CMS total time data. So if you look at the CPT codebook, I got these times from the CPT codebooks. It's 99201, 99 is 10 minutes, which is a new patient code. 99202 is 20 minutes. So you can do that based on how much time you're spending with the patient over the telehealth service, over the audio video technology. You can do that, but you also have to be mindful that there's also medical decision making that comes into play when you're seeing the patient. So you can either use the time that you spent or the medical decision making. These both can have different outcomes. You can have, you know, 99202, 20 minutes with the patient, but the medical decision making was higher because the patient had more issues, more problems, more detailed work that you had to go through in this visit. So you would probably go with medical decision making that will actually pay you higher. So it has to be either or, because the medical decision making can change your code and the time can also change your code. So refer to this table for your medical decision making or the time that you spent. So just remember that these are all based on telehealth services, okay? And CMS has not changed the audio video requirement. It does require for you to bill E&M codes using audio and video technology. You can use Zoom, you can do FaceTime, you can use Skype, you can use any of these platforms, but it has to be audio and video. There are some new changes on audio only visits, which I will talk about later. But right now we're talking about documentation guidelines, okay? I just put all this out there. So for medical decision-making, medical decision-making refers to the complexity of establishing a diagnosis or selecting a management option, which is determined by these factors. So you have to take into consideration how many diagnoses are you evaluating during this encounter. Does patient have chronic conditions? Are you managing diabetes? Are you managing COPD? Are you managing a coronary artery disease? So you have to take all these into consideration when you're making your medical decision making. The amount or complexity of medical records, diagnostic tests, or other information that must be obtained, reviewed, or analyzed. Are you reviewing blood work? Are you reviewing imaging results from the last brain scan? Are you going through some medical records that patient had gotten from their previous physician? So how long does that take for you to review those documentation, those results or reports? The risk of significant complications, morbidity or mortality, or as well as comorbidities, chronic kidney disease, hypertensive chronic kidney disease. These are related. These go together. Are there other problems that are associated? Are there diabetic manifestations that you are looking at? So those are a lot of those risk factors do come into play when you are documenting for medical decision making. Here's a chart that I found on CMS outreach website. Of course, they give you all this information. What type of decision making is it? Is it straightforward? That means that how many diagnoses are you managing? Is it minimal? Amount or complexity of data to be reviewed, minimal or none? Risk of complications, minimal. So all these three columns right here will give you which medical decision making you're going to have: straightforward, low, moderate, or high. And of course, always remember that medical necessity is always the overarching criteria. So medical necessity. So why are you seeing the patient in the first place? What prompted the patient to come and see you via telehealth? What prompted the physician to see this patient via telehealth? So medical decision making and documentation guidelines are super duper important to remember. I will give you some more information as to why I'm spending this much time on documentation guidelines, because there are audits, there are a lot of red flags that are being discussed right now by different parties. And we as coders, it is our responsibility to educate our providers into this, that just because the rules are relaxed right now doesn't mean that there's not going to be any audits later. That doesn't mean that these documentations are not going to be called in for review, and there may be some recoupment happening. So we want to be very, very mindful of how we are documenting for our telehealth visits. Okay, so now this is also new right here, audio only telehealth services. This has been expanded to great length. Like I said in the previous couple of slides ago, that audio video is still a criteria for you to build the E&M codes, which are the 99201 to 99205 for new patient, 99211 through 99215 for established patients. So that's also the criteria, but they have expanded the audio only services that you can provide. And if I can click on this, let me see if I can pull up that spreadsheet that's associated with it. Just give me a second. All right, here we go. If you guys can see, I know it's really small, but you have to pay attention to the code right there. Okay, so you have to pay attention. So right here, all right, there we go. So this is the code. These are the CPT codes that you see. Let me see if I can make this bigger. Can I make it bigger? Yeah, I can make it bigger. Okay, so list of Medicare telehealth services. Okay, so radiation management. So if you can look at this 1, 2, 3, 4, column 1, 2, 3, 4, column number 4, you can see that does this qualify for audio? Okay, so you have all of these. I believe these are all your behavior health, mental health codes right here. These are all qualified now for your audio only requirement. So you don't have to have an audio and video to provide this telehealth service. This is okay to do for audio only. So you have to pay attention to this column right here, number 4 column. If it says yes, you can do this service as audio only. If it doesn't say anything, if it's a blank, then that means no, you cannot provide this service as audio only. It has to be audio and video. So like all of these right here that you see, these are all services that need to be performed via telehealth. They're included in telehealth, but they're not included as audio only. So you can provide this as an audio video, but they do not qualify as audio only. Okay, so if we keep going down, we can see. So you don't, if you notice, we have not seen the evaluation and management codes here, because they do not qualify for audio only. So this is a really, really good resource. This actually just came out on April 30th, and I believe there are more than 200 codes in there. So look over here. All right, here we go. So if you look at the E&M codes right here, they do not qualify for audio only. Okay. Does that make sense, guys? I hope it does. Okay. The emergency department visits do not qualify as audio only. You know, nursing care. There are a few right here. So behavioral health, prolonged service inpatient does qualify. Smoking change greater than 10 minutes. This is counseling, I believe. Does qualify for audio only. So if you keep going down, you have to pay attention to our number 4 column right here. So we have about 240 codes that were added as telehealth to be provided via telehealth. Okay, get back to our thing. There is an increased reimbursement for these telephone services. So the codes that are 99441 through 99443, the payment was about $40 or something. But now Medicare is saying that they're going to pay for these services equivalent to an office visit, like established patient office visit. So we're looking at 992. So 99441 would be compared to 99212. 99442 would be compared to 99213. 99214 would be compared to 99443. And you can actually go on your Max site to see what your fee schedule is for these codes right here, and Medicare will match that. And this is effective March 1st. So if you were providing these phone services to the patient, then at that time you can actually bill dated back to March 1st, 2020, and they will pay. Oops, did not want to do that. They will pay equivalent to established patient visit. But the original rule for these phone services still stays. That still is in place, that you should not have had a related visit within the past 7 days for the patient, and it does not lead to an office visit in the next 24 hours. So that still applies. Okay, so be mindful of that. It doesn't apply. This rule does not apply for you to do an E&M code for via telehealth audio and video, but it still applies if you're doing a phone visit with the patient. Okay. And behavioral health and education services are eligible for audio only, which I showed you on the spreadsheet. There's about 240 codes. So based on your specialty, whatever your specialty is, you can actually make a cheat sheet for yourself and for your practice. Place of service is going to be 11 for office visits, because you're providing that service as an office visit. Also, another new addition here is that virtual check-ins, the G2010, which was a synchronic e-visit or virtual check-in, which was when a patient sends us documentation or labs to the physician, and physician reviews it. It was about $10 or something. That was only allowed for established patients. That has now been changed, and it's for new and established patients as well. The G2012, it's a two-way phone call, which was like, which only paid like $13. So I'm not sure if the reimbursement has gone up for these services or not. I don't believe they have been, but the phone codes, the 99441 through 99443, definitely has gone up, and it's going to be, instead of $40, you can get paid up to $100 if that's what your MAC pays you for a 99213 or 99214. Okay, so moving on. All right, so if you are a practice that is providing COVID-19 testing for your patient, American Medical Association released an update on April 10th, and they have the laboratory codes that have been added. So 87635 is and it remains your code for the testing of COVID-19. They've also added 3 new CPT codes for the antibody testing. So 86318, 86328, and 86769 were added on April 10th for the antibody testing. Also, these codes are not in your 2020 CPT manual, but they will be added to the 2021 CPT manual, but they are effective April 10th of this year. Even though you won't see them in your CPT code book, they are effective this year, but they will be officially in the CPT manual in 2021. This document right here that I have highlighted here, it pretty much says the same thing, but more in detail. I've just kind of bulleted it for you guys. What are the diagnosis codes that you will use? So the new diagnosis code that we have is U07.1, COVID-19, acute respiratory disease. And of course, these are other codes that you could use for your COVID-19 testing: possible exposure, actual exposure, coronavirus infection unspecified, other coronavirus. But of course, you have to make sure that you are meeting the medical necessity guidelines on these to be able to bill for these. Okay. Okay. So this is the same thing, the diagnosis codes. Okay, there were a lot of questions I had seen on APC forums and some Facebook sites that people are asking about the CES modifier. So yes, the CES modifier needs to be appended if you are if the cost sharing is being waived for a COVID-19 test. So what the CES modifier description is: cost sharing for specified COVID-19 testing related services that result in an order for an administration of a COVID-19 test. So if you are ordering a COVID-19 test for a patient, you will append the CES modifier for that. That means the CMS will pay you 100%, and you should not charge Medicare patients any co-insurance or deductibles for these services. So if a patient comes in, let's say, and you are doing a 99213 as an office visit code for the patient, okay? But you are sending the patient in for a lab, for the lab, for testing for COVID-19. For that 99213, you would append a CS modifier, and you will not charge that patient any co-insurance and copay for that visit. Okay. And of course, if you're doing if you are running these tests in your own office, then you will use these CPT lab codes as well. But mostly these CPT lab codes are for the laboratories. But the CMS is, but if you are swabbing the patient, they're not paying you separately for the specimen collection or handling. Okay, so that was all CMS. I know I went pretty fast, but I'll be happy to answer any questions later, right after I'm done here. But the commercial payers, I just wanted to say that they make their own policies and their own rules. So please check your commercial payers websites. And also it depends on what state you're in. So that also will make a difference as well. So Blue Cross Blue Shield actually updated their COVID testing FAQs on April 28th, which has been linked here. As I said, I will be providing this a PDF of this to everybody. I will upload it to the webinar site, so everybody who has attended today's webinar will get this email. They also did a telehealth update on 4/22/2020. Okay, so something that that Blue Cross changed in Texas that no one else did. There's now saying go back to place of service 02. So I don't know why they go back and forth. It's really frustrating to see this, because we've already made our practice management and billing systems a certain way, but to look for each of these payers who are making up their own rules, it's frustrating that they can't all talk to each other and be synchronized and do something that makes our lives easier. But it is what it is. So they're saying Blue Cross, as of April 22nd, is saying that you will use place of service 02. And they're saying you can do either modifier 95, GT, or GQ. So before it was all 95. They were saying, everybody was saying use modifier 95. But now Blue Cross is saying that use place of service 02, you can use modifier 95, GT, or GQ. So any one of them are fine. They're saying that there's no member cost sharing for covered services. I would like to hear from some of you guys to see what you are seeing as far as reimbursement is concerned. Are you seeing 100% reimbursement or not? I have actually seen that Humana is paying 100%. I haven't looked at any of the others yet, but I would like to see what kind of reimbursements are you guys seeing? Okay, so United Healthcare updated their COVID testing policy on May 1st. If you are a provider or a practice that is providing testing for the COVID, please look at that as well to see what their changes are. What their telehealth update is that they're waiving cost share from March 31st until June 18th. So they have an end date. So they're saying June 18th. Use appropriate place of service code as if the service was furnished in person. So they're saying, 11 for office visit, 21 for inpatient, 22 for outpatient, and they're saying modifier 95. So unlike Blue Cross, who changed it to 02, United Healthcare is saying use 11. I'm not sure what that change in 02 with Blue Cross is going to look like, because what we had learned from CMS was that if you were using 02, they were reducing the payment because 02 told them that it's based on a facility fee schedule. So I'm not sure if Blue Cross is going to reduce those payments or not, but I definitely know that using the place of service 11, 21, 22, any of the place of service that you would use depending on where the patient is, you do get paid higher than you would as a 02 modifier. I mean 02 place of service, excuse me. All right, and then I have Cigna here as well. Cigna updated their policy on April 23rd. They're also saying they will waive cost sharing related to COVID screening and treatment until May 31st. POS service normally billed, so same thing, 11, 21, 22, whatever place of service that you are using normally. And they're also saying that you would do GQ, GT, or 95 modifier. So just like Blue Cross, they're saying, you can use any of these three modifiers. So Blue Cross and Cigna are saying you can use any of these three modifiers. Humana is saying use the same place of service as you would see the patient in person and use the modifier 95. So some changes. I would highly recommend that you make a cheat sheet of this stuff. Have like a spreadsheet of all your payers and who's paying for what. Is there any cost share? Is there any what is the modifier that needs to be used? Is this covered as a telehealth or not? So because every practice, I would say that uses no more than 50 codes, depending on what procedures that you bill or what services. Well, you will not bill procedures for via telehealth anyways. So 20, 25 codes that you have, just make a spreadsheet, take some time and put all this information in one place so you have it available, and give it to your front desk, give it to your billing staff, so everybody's on the same page. Okay. So these are the policies for all the commercial payers. Hopefully, you guys can will click on these links when you get the handouts and see for yourself and relate it to your specialty or whatever specialty or place of service that you are practicing in. Okay. Also, yeah, I just wanted to, the reason I went through all the documentation guidelines earlier is because there's a lot of chatter out there. There's a lot of information out there, and there's a lot of people who are praising telehealth, saying it's the best thing that's ever happened to medicine and that this is great for the patients. And I completely agree. I do agree that the patients get to be seen in their home. Patients, physicians can just see the patient if they don't have to bring them in the office. This is super duper convenient, absolutely. But we also have to keep in mind that this is temporary. There may be some changes that will happen with telehealth going forward, or there may not be. We don't know that yet. So be very mindful that all these changes are temporary during the public health emergency. So it's very, very important to stay compliant with coding and documentation guidelines. It's extremely important. That's why I went through the documentation guidelines in this webinar, because I want you guys to be mindful that just because all these restrictions are lifted and all these waivers are granted doesn't mean that it's a free-for-all. Because you know what will happen after the PHE? Audits will resume. CMS will be like, oh, maybe we paid out too much, maybe we gave too much leniency, let's get all these documents to come and audit, and CMS can do that, commercial payers can do that as well. So they can look for fraud, waste, abuse, and they can look at all of that very, very closely. Funds may be recouped, they may process your future claims, and they may not give you any money because they're like, oh, nope, we reviewed some of your documentation and we don't think that you billed the way you were supposed to, or you upcoded or downcoded, whatever. So you cannot rule out fines, civil and criminal penalties as well. So if the fraud is detected, that could result in civil and criminal penalties. So please be very mindful of your documentation. Make sure you are staying compliant and documenting correctly. Okay. That's the auditor and me talking. Okay, and then of course, this is in every webinar that I do, stay connected. This is a constantly evolving situation. So as you have seen, that this is our 4th webinar in this series, and it keeps changing. So we try to stay updated as much as we can, and we try to keep you updated as much as we can. So new information is coming out daily. Stay connected, updated, follow official CMS and payer sites. AAPC, AHIMA, AMA, they all put out some great resources. So you don't have to read everything. You don't have to click on every link. You don't have to attend every webinar. Look for things that are relevant to you, to your practice. So you can get very concise information as well. So that's also that's also some good tips for you for time management as well, because I know a lot of us are like, oh my God, there's like so much information coming from everywhere. So what am I supposed to listen to? What am I supposed to look at? You make that decision based on your specialty and what you do for fee for service. All right, well, that's the thing today. So thank you very much, guys. Visit our website for more information on our services. You can send me an email if you have any questions. My office number and cell number are on here as well. Please like our Facebook page. It's called CodeRite Healthcare Consulting. Like our Facebook page. I post updates on our Facebook page all the time. Any new webinars coming out, anything that I see that is useful, any document or any update or guideline that I find useful, I post it on our Facebook page, so you will get it first. You can also connect with me on LinkedIn. If you are not on LinkedIn as a professional, you are missing out. So do check out LinkedIn. It's a great resource for professionals. And we also have a YouTube channel. So what I'm going to do is the recording of this webinar will be uploaded to our YouTube channel by the end of this week. We have all the previous recordings on our YouTube channel as well, and you can refer to them there as well. So thank you, everybody, and I will take questions now, and let's see if there are any questions here. Okay. All right, hold on just a second. I think I see some questions, but let me go ahead and okay, sorry. Sunita, come here, please. Okay, here we go. Oh, look at all these questions. Okay. Will there be a PDF for this webinar? Yes. Mm-hmm. Oh, that's okay. I'm okay with that. Yeah. Okay. Yes. The webinar will be the PDF will be uploaded and you will get a notification in your email. Yes. Okay. All right. Thank you. You're welcome. Yes, the PDF will be emailed to you. For a 5 to 10 minute Medicare telephone call, should we be using? Okay, let me see if I can expand this. Should we be using G2012 or 99441? You can use 99441. That'll get you paid more, Kayla. So you'll get paid more for that for sure, because it has been the reimbursement has been increased. Okay. In terms of vital signs, is it acceptable to document as patient stated? Yes, 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 it is. Please clarify now that some CMS telehealth services are approved as audio only. How do we report these services? Do we report the appropriate CPT code with the modifier 95? Do we report telephone CPT codes with these services as audio only? Okay, so if you are providing a E&M service to the patient, then you will use the codes 99441 through 99443. But if you look back at the, okay, let me see if I can share this again with you guys. Okay, if you look back here, what is that? So these are, if you are providing any of these services right here that do qualify as a audio only service, then you can bill that particular code for that service. But if it's just a regular E&M service over the phone only, you will bill the 99441 through 99443 depending on the time that's spent on the patient. Okay, well, let me get my questions again. Here we go. Okay, Arlene, I hope that answered your question. What we need to add modifier 95 to 12, no, you do not need a 95 modifier for the telephone calls. Why were 99441 through 443 codes added to the list of telehealth codes? Why? Because CMS is listening. CMS is listening to providers, saying that a lot of elderly population is not able to access audio and video technology. They don't have that. They're not very tech savvy. So 99441 through 99443 was added as a telehealth service, and they have increased the reimbursement. But I also want to tell you that this is not a telehealth service in terms of billing audio video. It is audio only, and they will pay you according to whatever the established patient code is. Okay. Since CMS is now showing telephone codes on the telehealth visit, should we now report these codes with modifier? No, telephone codes do not need 95 modifier. Okay, you're welcome. Thank you. You're welcome. So do we need to use modifier CR for? No, you don't need a modifier for your phone codes, for your telephone codes. No modifier is required for your telephone codes, but you do have to remember, I did say that you have to make sure that it is it's not, you haven't provided an E&M service to this patient within the previous 7 days, and it does not lead to an office visit in the next 24 hours. So you have to be very careful with that as well to bill your phone codes. Modifier 95 is not required for your audio only. No, modifier 95 is not required for your audio only. You are only putting my 95 modifier for your the telehealth services for E&M codes. Okay. Anybody else? I think that's pretty much it. All the questions I have. If you have any more questions, please do send me an email. Oh, I have one more here. Just 1 second. If you have already been paid on telephone calls, can we refund the payment and bill again since they are paying more? Ooh, okay, that is. So they are making it retroactive as March 1st. So you probably want to call the payer and ask that question to them. Either call your MAC, whichever state you're in, call the MAC for Medicare, or you can call the payer. So I don't know if I have the proper authority to answer that question. You would have to ask the payer that. Can we use incident to bill telephone visit? There, you know, Sonia, that's a really good question, and they're being very, very vague in that sense. For incident to only says that it's audio and video. So I would have to say no, because it does specify audio and video. So yeah, I would say no. I would be very careful in doing incident to. My position on this is that if you know, if you've seen the patient, you bill for the patient. If the provider, you know, if you're a nurse practitioner, if you are a provider, you've seen the patient, you bill for the patient. I know that providers get 15% more payment under their NPI, but please stick to the rules and do the right thing. I would be very careful about incident to, because there's really not a lot of proper guideline about incident to during this public health emergency. Just to clarify, annual well visits performed audio only. I report G40438 if done in office, patient at home. Okay, yeah, I think yes. I think the annual wellness is allowed by phone only. Let me go ahead and write this down, Arlene, because I will have to confirm that this code with you. I don't want to give you the wrong information here, and I will email you separately on that. Let me just make sure that I do my proper research before I reply to you. Okay. All right. You're welcome, guys. Everybody, thank you so much for joining. And yes, if you have any other questions, please send me an email. You will get the PDF of this as well. So do also like our Facebook page. Like I said, you know, all the update, all the upcoming webinars will be on there, and I would love for you guys to be a part of our you know, Facebook community. We do need more likes, so if you like this webinar, I would appreciate it if you gave us a like on our Facebook page. So once again, thank you so much, and have a nice, safe, and blessed day, everybody. Bye.